Good afternoon, everybody. Thank you for joining. My name is Jeffrey Hotch. I am the Chief of the Division of Health Policy and Management in the Department of Public Health Sciences. I'm also the Associate Director for the Center for Healthcare Policy and Research. It's my pleasure to welcome you to our seminar series. For some of you, this is EPI 291, and you're going to get credit for listening to our speaker and thinking about some of the research ideas that he's going to share. For some of you, this is CME, Continuing Medical Education. For others, this is just like a fascinating talk. And I'm welcoming each and every one of you. If I were going to introduce what we go through today to my family, I'd say, hey, today I got to hear a real cool speaker talk about really cool stuff. But if I were talking in front of a scientific audience, I would have to say, let us get technical with the jargon. With a background in environmental health and epidemiology, Professor Peter James's research focuses on quantifying how spatial factors such as access to nature, the built environment, food environments, air and light pollution, noise, and socioeconomic conditions affect health behaviors, mental health, healthy aging, and chronic disease. Dr. James has more than a decade of experience working with large prospective cohort studies, including the Nurses' Health Studies, the Framingham Heart Study, the Southern Community Cohort Study, where he has helped to create many geographically based variables and link these to health data. Professor James has developed mobile health technology, mHealth methodologies to assess real-time, high spatiotemporal resolution objective measures of location and behavior by linking smartphone-based global positioning systems, GPS, and wearable device accelerometry data, something like that, to understand how contextual factors influence health behaviors. Professor James has produced nearly 250 publications in the scientific literature, according to the UC Davis Profiles website. So if you see that his first publication occurs in 2005, and he has about 250, that's about 25 papers every year for the last decade. Wow. Professor James received his SCD from the Harvard School of Public Health and his MHS from the Johns Hopkins School of Public Health. Today, he will talk to us about embedding satellites, smartphones, and street views into environmental epidemiology. How cool is that? Thank you, Professor James, for speaking with us today.
Thanks so much for having me. Wow, that was a lengthy introduction. Covered a lot of the points I'll be talking about today, but let's dive right in. Let me know if the slides, can you see the slides okay? All right, so I'll be talking today about embedding satellites, smartphones, and street views into environmental epidemiology, and I'll explain what all those things mean in a second. So a little outline of the talk. I'm going to give us a primer and a little intro to the exposome in health, which is kind of the predominant theory that is motivating a lot of my work these days. I'm going to go into a lot of detail on nature and health as kind of a motivating example on how we study the exposome and health. Then I'll move into future directions in exposome and health research and talk a little bit about environmental exposure disparities and the climate crisis. And I'll end with just a little bit about translating research into policy and practice. So first off, what I study is how the places in which we live, work, and play influence our health, right? So a lot of this research is motivated by the eco-social model, which posits that individual choice plays a role. You can make a decision on what you do with your health behaviors, but the context that you live in may also influence what you choose. So it may influence your exposure to air pollution in a purely kind of environmental health perspective. It can influence your access to healthy food, your access to safe and inviting parks and green spaces to play and be physically active in. And of course, I also study how these different exposures and amenities cut across the racial and socioeconomic lines in this country and increasingly globally. So I love this. I spent a lot of time in Boston, and this is a statue in East Boston looking back towards downtown. And it says, a city is not an accident. And I think this really captures this idea of everything that you see when you walk out the door is a decision that somebody made, right? The places that we live, work, and play may be linked to health behaviors, obesity, cognitive function, mental health, which are major contributors to chronic disease risk, right? And these are truly ubiquitous exposures. Every single one of us is exposed to some type of built and natural environment. And really, these environments are modifiable, right? So this is a policy group. Everything that we look at when we walk out the door is a decision that we made as a society, whether it's land use policy, zoning policy, transportation planning policy. It could be an economic policy, right, that drives investment in a given area. And if I was in person, I'd have you raise your hands, but not many people know. But all of this that you're looking at in Boston was underwater back in the 1600s, right? In fact, right in the middle there, this is Long Wharf. It used to extend a mile into the harbor, just one long wharf, right? And now it's all been filled in. So basically, almost all of Boston is a decision that somebody made to put some soil. There's 3 hills in Boston originally. Now there's just Beacon Hill, and they dug out these hills and threw them in the harbor because there was some tax policy on how much land you could own at low tide, right? And so these policies drove this development in Boston. And if you ever go to Boston, you'll see that the road system is this chaotic result of slowly people building farther and farther out into the harbor. So this statute says the city is not an accident, but the result of coherent visions and aims, right? And so I think that motivates a lot of my work, thinking about this is not just something that we're exposed to, but really this is something we as human beings can decide how we distribute these exposures and how we distribute different amenities in our environments. So I mentioned this term, the exposome. In environmental health, we don't have a lot of omics. And so about 15, 20 years ago, we said, we need our own omics. So we need the exposome, right? So this is this idea of, can we study the totality of exposures across the life course, right? An ambitious goal, for sure. But it's basically, how can we understand all the things that we're exposed to? Before, we used to say, let's study air pollution, right? Let's study it in isolation and try and take this reductionist view. But realistically, we're not just exposed to air pollution. Air pollution occurs in places where there might be noise. Air pollution occurs where there might be less green space, right? So we kind of need to study these things in concert to really understand what is the driving factor. And this is a little diagram of the different ways you can study the exposome. This is kind of behavioral exposome. There's a lot of people who study, internal measures, biomarkers of exposure. And I really focus on what's called the external exposome. And that's kind of lumped in here, and they call it, climate, green spaces, traffic, social capital, lots of these things that are generally measured using geospatial data, right? And so how do we link geospatial data to health? So first off, I was lucky when I was a doctoral student. When I was at Harvard, there was this long-running cohort, the Nurses' Health Study. And my advisor at the time had geocoded all the addresses of the participants in the Nurses' Health Study to look at air pollution, right? So she had taken and this is a study from 1976 where we had address data every 2 years because we mailed their questionnaires. They were originally from 11 states, but they've moved throughout the US since 1976. They fill out these questionnaires every 2 years with questions about lifestyle, and then we also have disease and mortality follow-up. But the really crucial part was we had their addresses, so we could use databases to say, let's put a latitude and longitude, a little pin on the top of their house. And now this is the addresses across all years. Well, from 1986 to 2018, we're updating the addresses now for later years. But this is, shows you the distribution of addresses in this cohort. So we have health data and we have their addresses, right? We also have another cohort, the Nurses' Health Study 2, which is another 116,000 female nurses. And again, we've mailed questionnaires, so we geocoded their addresses. Then we have some male cohorts too, the Health Professionals Follow-Up Studies, about 51,000 male health professionals enrolled in 1986. They weren't originally from one state or a set of states, so they're all over the US. And we have geocoded their addresses too. There's also cohorts of children. So the Growing Up Today study is the Children of Nurses' Health Study 2 participants. There's about 27,000 GUTS participants, and they complete questionnaires about every year. So again, we geocoded their mother's address in this case, and now we're geocoding their addresses as they grow up, and now they're in their 30s, right? So we're keeping follow-up alive with these cohorts. So you take all that together, and you have this huge set of geocoded addresses, and then we layer on a lot of other spatial data sets to model proxy for exposures at the address level. So for instance, there's a lot of work with fine particulate air pollution. I know there's folks like Tony Wexler's group here at UC Davis, and Joel Schwartz at Harvard, and Joel Kaufman, University of Washington, lots of particulate air pollution, ozone, NO2, lots of different air pollution models where we can model the level of air pollution at your home address to the day, right? So that's pretty accurate. And these models are obviously validated with monitoring data, so they're pretty good. We also have lots of data on climate. This is the PRISM data set, which gives us information on temperature, but also humidity, precipitation. At the daily level, every 800 meters for the entire, I think the entire globe, but it actually goes back to the 1800s. So we have lots and lots of historic data on climate that we can link to our participants' addresses. We have a unique data set from the National Park Service where they measured noise over 14 years in different settings, both urban and rural and national parks. And they created a model to predict noise at 207-meter resolution. So we have a lot of metrics of noise, right? So this is median A-weighted decibels, right? But we have nighttime noise. We have different metrics of noise that we can link to our participants. We have built environment metrics. So this is a census tract level measure of walkability, which would be density, the number of businesses within the census tract, and then how connected the streets are, which are proxies of how easy it is to walk from place to place in your neighborhood. And of course, we now have wildfire data. So we have wildfire modeling data where we could actually predict the contribution of wildfire smoke to air pollution at a given address. And so these are pretty sophisticated models because they can predict the air pollution level minus what you'd expect to be there in the presence of just normal fine particulate matter. So this is the additional contribution of wildfires. So lots of really detailed analysis going on with Katie Conlon and other folks at UC Davis. But I really want to talk about green space because I think green space is a really exciting area of research for me. And what I do before I dive in is I start with my face validity slide, right? I think there's something of just looking at Yosemite that stirs something inside of me. And I think it stirs something inside of a lot of people, right? This idea that something about nature might give us this kind of visceral reaction and kind of get under our skin. Maybe your blood pressure shifts a little bit, this is adding credence to the idea. There's something about the beauty of nature that might, intrinsically move us. The biologist E.O. Wilson really made this term biophilia popular. And that's this idea that we've evolved with nature to have an affinity for nature, right? So we were meant to be in this type of setting, right? We were meant to be in this type of setting behind me and not sitting staring at a computer screen like I am in reality, right? This is where we thrive. And this is our natural default setting as human beings, right? And it doesn't have to be, Yosemite, right? It could be the Arboretum here at UC Davis. It could be maybe a houseplant in your house that brings you some joy, right? Who knows? We don't really know exactly, but that's one of the things that we're trying to study. There is also some theory. So one of the theories is what's called, let me see if I can get this to play, attention restoration theory. And this is this idea that urban environments really tax our attentional control. I'm staring at my computer screen right now and I have to concentrate because I don't want to look stupid in front of all of you, right? And that takes a lot of my focus, a lot of my my effort, right? And something about being in natural environments and watching trees sway, although they're not swaying much anymore there, something about this allows us to restore that directed attention. It's this like indirect attention. Something about being away in these natural environments allows us to perform better on memory and attention tasks. And there have been clinical trials to test as people flip a coin, have you walk in an urban environment, have you walk in a natural environment, and then do a cognitive test before and after. And people perform better on these cognitive tests when they spend time in nature. There's also stress reduction theory, and this is this idea that something about nature activates our parasympathetic nervous system in a way that reduces your stress, right? It allows you to kind of have positive affect even when you're undergoing stress. Again, this is this kind of evolutionary theory that something about nature is where we're supposed to recover from stress. I think about it this way, if you go to a spa, they're playing nature sounds, right? That's what we associate with kind of healing and calmness and stress reduction, right? And there has been a number of clinical trials where they have, again, they're having people walk in green spaces versus urban spaces, doing questionnaires about their stress levels before and after. And we do see a stress reduction, including some biomarkers for stress after walking in natural settings. And if I have the time, you may have heard of this famous study in 1984, where they randomized participants in it's actually patients in a recovery room floor of a hospital to beds that had views of nature versus beds that had views of a brick wall. And the patients that had views of nature recovered in shorter amounts of time, requested fewer pain meds, He had fewer negative comments from nurses, which is an interesting outcome. But that is kind of an interesting clinical, randomized trial to say something about just viewing nature might benefit us, might help us to recover from stress and injury. But my research, I really want to dive into more, how do we understand how nature might affect long-term health outcomes, right? Chronic disease, et cetera. And so this is a little schematic. It's a little dated, but basically, access to green space and then contact with green space may impact these four pathways. So the first one is air quality, but I like to think about it as environmental factors. So green spaces may have lower levels of air pollution. You may be buffered from exposure to noise. You may have some buffering from extreme temperatures, and that might lead to health and well-being benefits. Green spaces might provide you a setting to be physically active in, and physical activity has strong links to improved health. Social engagement might be more likely in green spaces, and social engagement also is independently linked to health benefits. And then finally, it's stress, but I think of it as stress and cognitive function. There might be a direct benefit for stress and attention of living in green spaces, seeing green spaces that might have long-term impacts on health and well-being if we look at this exposure over long time frames. So again, this sounds great, but how do we actually study this? So going back to the Nurses' Health Study, we have these questionnaires sent to nurses over time to have prospective data, and we have the residential addresses. So what we can do is we can create exposure metrics on green space by taking a hypothetical residential address and then overlaying data from, for instance, this is satellite data on what's called the Normalized Difference Vegetation Index, NDVI. It's an index of vegetation. So every 16 days, every surface of the globe has an image taken of it. And we can look at the reflectance of vegetation, which happens to scatter near infrared light to keep from overheating and absorb visible light for photosynthesis. And we have this unique spectral signature that we can measure using this vegetation index to say, here's the quantity of vegetation in this pixel. And we can say, okay, this participant lives there, we're going to give them that value. Or we can look at a buffer around their home and say, here's the average of all the vegetation in a 1,200 meter buffer around their home, right? So we're using GIS, geographic information systems, to calculate these exposure metrics. And we can do this over time because we have prospective data and create cumulative exposure at your residential address to green space over long time periods, right? And so I'm going to walk you through a few of our studies just to hopefully prove that there's some strong evidence for how nature impacts long-term health outcomes. So first, we created these measures of greenness. This is looking at 250 meters around their home, cumulative average from 2000 to 2008. So about 8-year follow-up in the Nurses' Health Study, 108,000 participants. We binned people into quintiles of green space. So that vegetation index, we said, these people are living in the most green areas. These people are living in the least green areas. And what we found is that the people living in the greenest areas over follow-up were about 12% less likely to die at any given year, right? So, and that is adjusting for lots of other factors, including individual socioeconomic status and census tract median home value and income, right? And we ran lots of other sensitivity analyses. It was a pretty robust finding. We also ran a mediation analysis. So you remember those kind of 4 pathways I talked about earlier. Well, because we'd measured a lot of these things in the Nurses' Health Study, we'd measured physical activity, air pollution, social engagement, and mental health. We could say how much is the greenness and mortality relationship explained by these different pathways, right? Physical activity, air pollution, social engagement, mental health. Turns out physical activity really didn't explain much, about 2% of the association between greenness and mortality. Air pollution explained about 4.4%. Social engagement explained about 19%, which is really surprising because we really used a pretty coarse measure of social engagement. Do you participate in group activities more than once a week, right? So I was really surprised with that. But mental health, which we used doctor-diagnosed depression or antidepressant use as our kind of mediator, that explained about 31% of the association, meaning that people living in greener places were less likely to become depressed over follow-up. And also people who are depressed were less likely to die over follow-up, right? So that was an interesting contribution to the literature there, where we kind of got to tease out the different pathways through which nature might impact health. Since then, we've done analyses looking at just depression incidence in the Nurses' Health Study. Here again, we've binned people into these quintiles of exposure. I'll point out that we threw the kind of kitchen sink at different covariates, and we also, we reduced our sample size a lot because we wanted to make sure that nobody got in to this prospective study if they had depression at baseline, right? or any sort of metric of depression at baseline. And we still found about I think 13% lower incidence of depression in the people living in the greenest areas. So that was interesting. Since then, we've kind of grown this science, looking at lots of outcomes, cognitive function, physical activity, sleep, cancer, et cetera. And we're trying to do this more from an exposomic framework, right? One of the interesting things we've looked at recently, and a lot of my work is looking at aging now, is that we found that greenness exposure in adulthood is associated with slower cognitive decline. So this is repeated cognitive testing. And we've seen that the slope, if you're living in a less green area, of cognitive decline is a little steeper than if you're living in a greener area, which is equivalent to about 8 months a year of slowed cognitive decline. We've also used other data sets like Medicare data sets, where we were looking at Alzheimer's disease and related dementias, ADRD, and that's on this top row, and then also Parkinson's, which is on this bottom row. With Medicare, we're only able to access zip code level data. So we couldn't do the residential address, but we could get your zip code and we could create measures of NDVI, again, that vegetation index, park access from a park data set, and then also blue space or water access with another data set. And this was 62 million Medicare beneficiaries. We looked at hospitalizations for either ADRD or Parkinson's. The interesting thing here is we also were able to account for particulate matter, NO2, gaseous air pollution, daily temperature, specific humidity, and precipitation here. And this is maybe not the clearest slide, but these are point estimates on the left-hand side here, where we basically see about a 5% lower rate of hospitalization for ADRD with a higher level of NDVI, and about a 6% lower hospitalization for Parkinson's with an IQ or higher NDVI. And so then also we see some suggestion for park cover also is protective. And then for Parkinson's, we saw that blue space also might be protective. So for Parkinson's, we generally saw that all of these estimates seem to be protective for all the different metrics of nature. And for Alzheimer's, is really only NDVI that was strong. And then we have lots of stratified analyses. So I've kind of thrown the kitchen sink at you here with all sorts of findings. I'm sure you're thinking about, well, I'm a little skeptical on these things. So where are we headed next? How do we improve on this? So first off, there are some limitations, clear limitations, right? I think one of the ways of framing this is like, is greenness, this vegetation index around the home, the right measure? First off, what area around the home? Are people actually going and spending time in nature? Or is this just some weird, like I may live near a green space, I never go there. Why are they using this measure, right? And then, this vegetation index, we don't really know what that vegetation index represents, right? It could be a beautifully manicured park, or it could be agriculture, or it could be an overgrown vacant lot, right? And if it has the same NDVI value, you can't distinguish between those things, right? So what are the specific active ingredients in nature? And I hope we think about this in Chipper. I know that we think about this a lot in my group, but like that specificity, and in causal inference, we call it consistency. The idea that we are trying to simulate randomized trial when we design observational studies. But what is the specific exposure? If NDVI can be changed in hundreds of different ways, right? There's a lack of specificity in that actual causal question, right? And so that's, interesting from a causal inference perspective, but it's also really interesting from a policy perspective, because what do I tell, the mayor of Davis? Increase NDVI by 0.1, right? There's 100 ways to do that. What type of guidance can I give? And would we potentially not see any benefit if we increase NDVI by just planting grass, right? Maybe there's other specific things we need to do. So we're trying to get better at this. So how are we doing this? So first off, we traditionally define exposure on the home in spatial epi research. That's just because we're looking under the lamppost, right? Lots of studies with geocoded addresses and health data. So we look at the home. But we know people spend less than 50% of their time at home, and this contributes to massive exposure measurement error, right? We also know we measure health behaviors in cohort studies fairly poorly. In fact, a lot of our health recommendations on physical activity, diet, sleep come from questionnaires like this, where we ask you, during the past year, what was your average time per week spent in each of the following recreational activities, right? Walking for exercise or walking for transportation errands. You fill out a bubble and we bin you, right? We like kind of give a score of, oh, we're going to give this activity a 2. We're going to give this activity a 4. And we add up to get what's called a MET, a metabolic equivalent of task hour, right? And that's what guides our physical activity recommendations, because we then follow people forward for cardiovascular events, cancer, et cetera, right? But we know we're not capturing that perfectly, right? If you ask me in February versus July, I might answer very differently. And I may not be able to accurately respond about the past year of my physical activity. Similarly, sleep, how many total hours of sleep per night, or total hours of actual sleep do you get? I don't know what that means, but this is not necessarily something that I do consistently every night, get 8 hours, right? There might be ups and downs. The quality of my sleep may vary. The timing of my sleep might vary, right? If I'm going to bed at 11 versus 3 a.m., that might be very different, right? So there's a lot of error also baked into our health behaviors. So how we've tried to address some of this is in yet another cohort study, the Nurses Health Study 3. When I was at Harvard as a postdoc, I wrote a K99 to try and address some of this using mobile health technologies. And so in this cohort study, now it's about 50,000 nurses and nursing students aged 19 to 46 across the entire US. We're still recruiting, so nhs3.org. If you're a nurse or know a nursing student or nurse, please ask them to sign up. But these participants fill out web-based questionnaires every 6 months. And we noticed that participants were opening emails using predominantly smartphones, like 95% are using mobile operating systems. So we thought this might be the perfect cohort for some mobile health technology. And so back in 2018, I started the Nurses Health Study 3 mobile health sub-study, where we gave 450 participants a Fitbit and then asked them to download a custom smartphone app that measured location and administered questionnaires. So the Fitbit measures steps and heart rate and sleep at the minute level, and the smartphone app really just measured GPS every 15 minutes and very brief questionnaires, right? But the beauty here is we got efficient, passive, objective, and low-cost measurement of high spatiotemporal resolution data on location and health behaviors, right? So now we can look at environmental exposures from moment to moment and behavior from moment to moment and really understand things better. So this is a little plot of my data. This is 1 week of my data. And so the purple data is heart rate. The green little dots are steps, which track with the heart rate a lot. And this kind of teal horizontal line is latitude, just to show kind of that we were getting a GPS point. And so you can see lots of variability in my physical activity within a day, also from day to day. You can see I went for a big run. You can also see I turned off the phone for a little bit, right? I had some missing data, but we can see a lot of variability in behavior here, and that might give us more insights into more relevant metrics of physical activity that might be relevant to health. We also can see dipping in heart rate, which is a really nice way of identifying sleep periods. And so this is that data on a 24-hour clock, where every different color here is a different day of heart rate. And you can see the gray shading is where Fitbit recognized my sleep period. And this is when I flew to California from Boston. So you can see as my sleep period shifted to match the local time zone. So we can identify things like that. Remember, these are nurses. So we can identify shift work. We can identify when there's mismatches in their sleep behavior, and that might be relevant for health, right? We can identify all sorts of circadian markers. We can look at variability in sleep timing and duration. And at the very simplest methodological way, we can look at how well do our objective measures match our questionnaire data to see if we can do some measurement error correction on our questionnaires and apply that to the full cohort. But again, I'm an environmental epidemiologist. I really care about the spatial data. So this is my old data from when I used to live in Cambridge and I used to work right near Fenway. And you can see this is me commuting back and forth. You can see me spending all my time going around work and then commuting back to Cambridge and then, kind of back and forth. This is my data for a week, right? And so, fairly monotonous going back and forth from home to work, but, spent some time in South Boston and South End. Worth pointing out that when I showed you that address and that buffer for NDVI, right? That was the size of maybe one of these circles, right? So really, if we were looking at my home address, we would just look at my exposure right here, and we would throw away all this information about other places I spent time. So we're losing a lot of information about exposure. And so to kind of put it all together, we are now designing studies where we're doing this kind of momentary analysis, right? So we have our GPS data, we have the activity at a given location, and we extract the value of, for instance, vegetation data to say, oh, look, this person had a bout of moderate to vigorous physical activity. They're more likely to be physically active in greener spaces, right? So we can get this data that actually tells us where an individual within a person is more likely to be active and what are the environmental drivers of that. Now, it's hard, causality is still tricky here, but we can say at least they were more active. Maybe they chose to go there because they wanted to be physically active, but again, that setting is a place where they chose to be physically active, so that might be worth thinking about. We're now scaling this work up. So we're kind of digital phenotyping is this kind of fancy term of using just smartphones. And BWE is one of the apps that we use. It was developed at Harvard School of Public Health by a biostatistician who's from Finland. BWE, I guess, is a Finnish god. And so this app allows us to collect smartphone-based GPS, but also smartphone accelerometry, sleep and social network data. It also is a platform that allows us to instantly process that data in AWS infrastructure, other than AWS going down yesterday, I think it was. But in general, this is so much more powerful than trying to gather this data and download it locally, even onto a local server and process it. It just takes a lot of time to transit that data, and it doesn't make any sense. And nowadays, we can use existing algorithms in the cloud and process our data. So this sub-study is actually in the Nurses Health Study 3 and the Growing Up Today study, which I mentioned earlier. We actually asked about 2,400 participants to undergo a year of passive data collection and then answer questions every 10 days. So basically, the phone's running in the background on their phone. They only have to interact with the app every 10 days and answer a few questions just to keep the app active so the operating system doesn't kill it. And enrollment started in 2021. Data collection ended in 2023. And this is like a little visual of each one of these lines is one participant, right? And you can see as we kind of slowly enrolled participants, and in total we had 200 gigabytes of GPS data, 9 terabytes of accelerometry data, and then raw surveys here. The nice part about this is this dashboard, I think it was in Tableau, allows us to identify like the Apple operating system went down for our app. So you can see this little gap here where all of a sudden we lost a lot of participants. So this dashboard helped us to identify that and go and contact those participants and see if we could fix the issue. This data is really rich, right? This is 11 terabytes, 127 million participant minutes of GPS and accelerometry data, right? On average, we had about 226 days per participant. So we had more than half a year per participant of data. We knew we weren't going to get a full year. That was our pie in the sky. We said, let's go for a year and see what we get. We averaged about 13 valid hours of accelerometer and GPS data per day, and we got 23,682 micro surveys on diet, sleep, physical activity, mental health. Response rates ranged from 40 to 50%, which is what we'd expect with this type of protocol, right? You get a ping on your phone and you might just ignore it. But if we get enough data over time, it's kind of a rich, repeated, longitudinal, what they call intensive longitudinal data. And again, we're processing this data right now in AWS servers. So some applications of this data. So we now have, a year of data. This is my data for 14 months. I had the app running on my phone. So we have lots and lots of data now. Before, we just had me commuting from home to work. This is during COVID. So I spent a lot of time going to random little places all over Boston. But, we can, for instance, answer methodological questions on how many days of GPS do we actually need to measure exposures? Like, is a month going to tell us the exact same thing as a year? Right, so we may see that we don't need this variability, or maybe we need to do it every season to capture variability. We don't know those answers, so we can try and get at that. We can also create personalized exposure measures, right? So that's part of the idea here. Is GPS data doesn't need to be captured on everyone, but if we can say that, look, GPS-based exposure pretty highly correlated with residential-based exposure, then we feel a little more comfortable with addressing that having that as a limitation in our full data sets. And then we're also incorporating ecological momentary assessments. This is basically pinging people on their phones and asking about mood, behavior. So like, for instance, right now I feel happy, right? And you could ping, obviously you strongly agree because it's such a compelling presentation, right? You would strongly agree that you're happy. And right, we couple this data with continuously measured GPS and accelerometry to say, where you were may influence your mood, or where you were an hour ago might influence your mood right now, or where you were over the past 24 hours might influence your mood, right? So we're working on analyses there. And we have lots of this data already, 23,000 microsurveys on all sorts of constructs, pets, fruits. There's a lot of diet because the PI for Nurses Health Study 3 is a nutritional epidemiologist. There's a lot of diet questions in there, but we have a lot of questions. So we can look at how environmental exposures and how behaviors are influencing these kind of self-reported behaviors from moment to moment. This is one example of, for instance, quality of sleep. This is something you can only get by asking about it, right? We can't get this from objective data, so we need to ask people about their quality of sleep the night before. We also now have a new grant that was funded by the National Institute on Aging to look at remote assessment of cognition through smartphone apps. So we're asking about 1,000 participants to download this ambulatory research and cognition app, which allows us to do repeated cognitive tests, take about 2 minutes or less. They deal with kind of practice effects. You can't get better at them because they keep mixing it up. And obviously every cognitive test is time-stamped and geotagged, so we can actually look at these data and see how environmental exposures, again, an hour that you took it, or the 24 hours prior, how these kind of moment-to-moment exposures might influence your cognition. So that's really exciting. We get to look at that in the next few years. So next, we kind of have this idea on, we've been talking about behavior and GPS data, but what about this vegetation index, right? How can we improve on our exposure assessment? So there's been a lot of work, and this is not my work, this is other computer scientists using deep learning algorithms and AI now to understand better what's in any image, right? And so we're trying to incorporate image-based approaches to exposomic research. Basically, satellite-based data tells us very little about the quality of natural and built environments on the ground, but geocoded street-level images like Google Street View provide insight into specific environmental features from the on-the-ground perspective as we would likely experience them. And really, these machine learning, deep learning, AI approaches, they're just fancy ways of scaling this up. So I don't have to sit down or pay a research assistant to label millions of images, right? These algorithms can do this at scale from hundreds of millions of images. So that's pretty powerful. So we go from this top-down perspective to something like this, right? And so this is the segmentation approach we're using, which is now dated. I thought it was so cool, but like 5 years, and now people are like, why are you using this? But this is a PSPNet algorithm, which is a segmentation algorithm. It basically takes all the context in the image and it assigns every pixel a different class. So we can say this pixel is a tree, this pixel is grass, and it gives you kind of accuracy. It's like it's been tested on validated data sets to be like 95% accurate at the pixel level. So we can take the grids of streets across the US. So we've done this for every street in the US, for every city. We did every 100 meters along the street, and we pulled the nearest Google Street View image, and we picked them from 4 different orientations. You can see here, every year there's updated Google Street View images for not every location, but a lot of cities have it almost every year, and other places have it every few years. But basically, for a given image, for a given location, we take 4 images to get a 360 degree view, and this is the same location 2 different years. Then we take those images, we process them using this deep learning algorithm, and we have, for this location, there's 23.6% trees within view, there's 22.3% roads within view, 13.3% grass, up to 150 different items. Some of them are indoor items that we wouldn't expect to see, but the algorithm is meant to look at it. Yes?
Sorry to interrupt, but I think you just said you did this for every street in the United States?
Every city in the United States, we did this every 100 meters. So in the end, we downloaded 350 million Google Street View images and processed them over, it took us like a year in one of the Harvard Medical School servers to slowly churn through. And now I would bet we could do it. I mean, we just downloaded all of Europe for most of the cities in Europe, and we've done it for now updated. This was like 2022, and I think we've done now 2023, 24, 25. And it's so much faster now. Like everything is just exponent, Moore's law. It's just getting faster and faster. So, and there's now all these other algorithms that can identify with, better accuracy things within view. So we're trying to publish on this, and we get pushback saying, why didn't you use this algorithm? I'm like, well, it wasn't available 5 years ago when we got the grant. But, we're happy, anyone on the call, if you'd like to collaborate, if you have ideas, we are definitely, we have the images and we can certainly share. I mean, that's the idea is we don't want to just have these images for us to use. We want to create new metrics from them. So I'll just point out that this was the NHLBI grant, the R01 that funded this work. And now we have these layers. I mean, you could take the raw images, but also I'm happy to share what we call the raster. So this is basically a surface, or anywhere we had a Google Street View image, we could create now, instead of NDVI, this is percentage of trees within view, or percentages of grass within view, or percentage of other green, which is like fields, flowers, and plants, other types of green space from the algorithm that was much less frequent, but we still wanted to include other types of green space too. And so this is New York, Chicago, and San Francisco. And you can see they're not the same thing, right? And we've looked at this with NDVI. It's not the same thing as NDVI. So we are definitely getting some unique measures. This is just showing in the nurses' health study. We linked it to the addresses of participants. These are the different quintiles of these different measures, some representative locations, so you can get an idea. And basically, other green is shrubs. It seems to be really just coming out as bushes or ornamental shrubbery. But here's grass, here's trees, right? So we have a paper that hopefully will be accepted very soon, where we've actually looked in the nurses' health study at how exposure to these different factors is related to cardiovascular outcomes. So overall cardiovascular disease, MI, myocardial infarction, or stroke. And we're finding that trees in our fully adjusted model, trees are protective. There's a protective association between more trees from Google Street View and lower rates of cardiovascular disease. However, for grass, we see actually an increased risk of cardiovascular disease with higher levels of grass. And this is true primarily for MI. Stroke is a little less strong. And other green also, we see a small but elevated risk if you are living in a place with other green. So trees protective, grass harmful for cardiovascular disease when we look at these Google Street View measures. We're also trying to now create measures of green space quality. So we've had using Mechanical Turk, basically paying people to rate images, saying which ones are more beautiful, which ones are safer from crime, which ones look safer for walking, which ones have higher quality green space. And so we have people, rate about 10,000 raters rating images. And then we created another model that says, now we're actually looking at quality of these Google Street View images. We apply that algorithm to all the images we have. And our surfaces now are looking at different metrics of built environment quality. So we'll see what those show. That's kind of hot off the presses. But so I'll just end in maybe the next 5 minutes. We have time for questions. But first off, we're not the only people who've done this, but many people have looked at how access to nature is strictly cut across racial and socioeconomic lines in this country. We did a study, maybe like 10 years back, maybe more than 10 years, where we looked at access to green space and race, ethnicity, and income. This is just showing NDVI on the x-axis, and here's the racial composition. You can see that places with higher levels of green space are predominantly white, while areas with low levels of green space are much more diverse. And this exposure disparity has persisted over generations, which could contribute to health disparities by race and socioeconomic status, if we believe that these relationships are causal. We have also done this with Google Street View metrics, and we again find that in general, trees are going to be much more cutting across racial lines, where white neighborhoods have much higher access to trees. And this is the change in Street View trees. This hasn't really changed much over time. So this is also really important, as there's this concept that was really popular in Europe of this idea of equigenesis. Something about green space seems to decrease health disparities. So this study was done in 2008, where they looked at cardiovascular disease by income, and they saw in the least green areas, there was this big gap between the wealthy and the poor in terms of cardiovascular disease. But then in the greenest areas, these health disparities by income were much smaller. So there's this idea that something about adding green space, it might help to benefit the poor more, and so it decreases health disparities. So that's compelling, especially compelling in light of the fact that USDA, before the Trump administration, funded $1.5 billion in urban community forestry grants across the US for only disadvantaged communities. And from what I understand, this money had already been granted, so it cannot be taken back. So a lot of these projects are still going on. And so I think this is a real opportunity to study the health effects of these natural experiments. So we're really trying to get in with groups like in Rise South City and South San Francisco to understand how exposures change and health outcomes might change before and after planting trees. Another thing to keep in mind, and I think for a policy group, this is something certainly you must be thinking about, but there's also this concept of green gentrification, right? That we could come in and say, look, we're so great, we're these saviors, we're going to green your neighborhood, it's going to be good for you. But these low-income communities, people of color, have contributed the least to climate change, are the most exposed to climate hazards, and have the fewest resources to adapt, but are also the most likely to be displaced by these greening projects, right? As you come in, build a new park, you displace people, you raise the property values. So how do we come up with sensitive ways of improving green space without displacing people? And my colleague Isabel Anguilowski in Barcelona is kind of at the forefront of this, where she's thinking with groups about how do you work with actual populations, see what they actually want to plant, instead of saying, oh, we know what works best, we're going to come in and just do it. And then, of course, even though I'm not allowed to say this anymore, but the climate crisis is still occurring, right? And green space has massive co-benefits for human health and the health of natural systems. So it's a major carbon sink, prevents soil erosion, prevents substantial cooling, right? And so also in the context of equity, I talked about the health effects being different, but I mean maybe one of the pathways is that low income areas have less tree cover, as I mentioned, and they're also hotter during extreme heat events. So this is going to magnify the effects of climate change for low income groups. And so really nature-based solutions, planting trees and other types of vegetation may be an important tool to address both climate and health, and really a co-benefit for everything. Obviously, wildfires are another thing to think about, especially in this setting. We need to think about that as well. But other sensitive ways of thinking about how do we plant trees, how to incorporate green space into our environments in a sensitive way. And then I'll just end here with a little bit on translating research into policy and practice. I was really lucky when I was in Boston for starting as a doctoral student, but all the way up through postdoc and faculty, that I was able to work with the Metropolitan Area Planning Council, which is Boston's regional planning agency. This is a state agency where most of the people there originally were urban planners, right? Transportation planners. And they, through the work of my colleague Mariana Arcaya, who was trained as an urban planner and a social epidemiologist, she was working with them to incorporate public health into their work. And actually now they're one of the first planning agencies to have a public health department. And so I was really lucky to work with them to first, we were using things like health impact assessments. So you may have heard of environmental impact assessments. We used health impact assessments to understand what are the health impacts of planning projects, right? How can we project forward and say, oh, if you change the cost of the subway, the T in Boston, how does that influence behavior? How do people start driving more? Are they more sedentary? Are they exposing us to more air pollution? And what are the downstream health effects of that? And then what's the dollar value we can put on that, right? And so one of the most impactful things we did is some of this work on a healthy T for a healthy region, which got a lot of attention. It was held up at the State House when they were trying to increase the fares on the MBTA in Boston and also cut service. And I think it was effective, at least part of the conversation, in terms of kind of cutting short some of those cuts and driving the conversation. Now it's a constant argument, and everyone's trying to tighten budgets, but I think it's really important that people in public health are at the table for these types of decisions, because if we're not, they just don't incorporate that type of information into policy decisions. And so I feel like folks at CHPR are probably much more attuned to this than I am, but I was really happy that I was able to kind of do some translational work and take some of the research that we do and quantify some of these health effects of different planning decisions. So I'll end there. I don't know if I need to recap on all these conclusions because I want to leave more time for questions, but I think that the most important thing is that all the data that I'm talking about, all the things I'm talking about, are really supposed to provide relevant and actionable information for planners and policymakers and community members to design communities that are optimal and equitable for health, and that also may help us to address the climate crisis. So just want to acknowledge a lot of my collaborators and some of the funders for this work. And there's my email, and I look forward to the questions.
Thank you very much, Professor James. That was so interesting. We're going to open up the seminar now for questions. You can type something into the chat if you'd like. You can turn on your camera and actually raise your hand. You can do the virtual hand raise if that's your thing. Earlier, I had said that Professor James had done 250 papers in 10 years. That makes him sound prolific or something. It was actually 250 publications in 20 years, which is still about one paper every month for 2 decades. So I wondered, Dr. James, do you have any advice for especially young and new researchers who are thinking about how to write and how to get going writing and how to get started on research? Because you're very prolific with lots of good ideas, but it's sometimes difficult if you're just starting out to figure out how to develop such a pace and maintain it.
Yeah. I think the important thing for me is being a collaborator, right? I mean, there's no way I'm writing all those papers. This is trainees and other really smart, hardworking folks who are coming up with great ideas and moving them forward. I think it's really important to collaborate. And I think one of the things I've been really lucky to do is to reach across different silos. So for instance, I mentioned like the National Park Service noise data. I just emailed these folks at the National Park Service when I saw something in the Smithsonian magazine, right? And I said, this would be really cool. Can we link this to our cohorts? And same thing with a lot of the work I've done on green space. This isn't my work and my methods. This is me talking to computer scientists, talking to satellite folks, remote sensing folks who know a lot more about this, and having them as collaborators just builds on so many papers, because there's new ideas, there's new ways of kind of joining different types of data, and we all have our complementary expertise, and I think that's really important for me.
Super. There is a question in the chat. I'm going to call on Snigha to, if you're okay, to go off mute and share your question with Professor James.
Yeah, definitely. Well, I mean, as it's kind of like my question is like, where did your like research on like environmental factors begin from? Like, what was the motivation to start researching this area?
Yeah, I've thought about this a lot as my origin story here. And I often talk about, so I grew up in Washington, D.C., and I have some slides on this, but not in this talk. But I grew up in D.C. in the 80s. And it was, post the Martin Luther King riots. There was a lot of crime. There were a lot of abandoned buildings, and it was a pretty rough built environment to look at and to live in. My dad was mugged multiple times, and I think after college, I came back to DC in the early 2000s, and I just saw this city just changing so much. And I just became really engaged in like, how does this change? Is this change good? Is it going to benefit everyone equally? I started working in public health, and I really said, oh, actually, this is like a health question. And so it was kind of just, I don't know, fate, luck, that I was really interested in the change in DC. And I was studying health, and I realized there was a place for that conversation in terms of, oh, it's not just about money. It's not just about there are downstream consequences for health. And that's what motivated me. Another part of it was at the National Stadium. So the baseball team, actually have a cup right here, and I can't see it anyway. But the National Stadium was going to be built. The Nationals were a baseball team. They're moving back to DC after being away for many years. And there was a lot of debate about eminent domain, kicking people out of their homes, and where they're going to put the stadium. And I just was like devouring that information and really, really interested in it. In the end, I honestly don't think they displaced that many people. It wasn't that terrible, but I was really, really engaged in that thought. The being thoughtful about how do we look at public goods and private entities, and how do they, is it okay to displace somebody so that a company can make money? Of course, now I still like the team, although they're terrible. But it was certainly something that got me engaged in the question of how does the built environment and changes in the built environment impact people?
Super, thank you. We have time for one more question. There is a question, and I wondered if you could talk a little bit about the center that you run. For example, not only what they do, but how is it organized? Is it like an ORU, or is it like something else? Could you tell us briefly about your center and your vision for it?
So I direct the Center for Occupational and Environmental Health at UC Davis, which had been around for a long time. I think was dormant for a little bit. As far as I understand, we are not, we don't stand on our own as a ORU, but we are trying to we have a new faculty member. We just started in October, Cindy Lango. So we're really excited to have her in, and we're really trying to build out our center and understand like where we can situate ourselves to be most helpful. So we're thinking about programming in terms of pilot grants, in terms of having seminar series, but also building out affiliate members and trying to kind of right size ourselves to say what's actually a benefit as another, as opposed to some other redundant, a specific aims review, and the Environmental Health Sciences Center already does that, right? So we're trying to figure out where we can sit. And we do occupational research, but we also do purely environmental health research, and then kind of things that are both. And so we kind of want to motivate that mission, and kind of articulate what our mission is truly going to be as we have incident starting and are kind of fully staffed. So we'll see. Look out for us in the next few months as we kind of relaunch.
Super, super. And I'm going to give you, as we're running out of time, the opportunity to share with us your final thoughts for today. What's the one thing we should take? Not that it's not easy being green, maybe that it's important to be green, or what's the take-home message for us today?
Well, I think the take-home message, usually when I talk to the press, a lot of people will read this type of research and they think, oh, that means that I've got to go out to Yosemite this weekend, or I've got to go and spend more time in, some sort of immersion in nature. And I actually think that's not what the research says. What the research says is that we need policies to maintain green spaces and nature in our cities for everyone to thrive. And I think it's really on our policymakers to look at green space, not only maintenance of green space, but also actually creating new green spaces as a huge benefit, not only for health, for the climate, for all sorts of different outcomes. And I think if we quantified that the same way we do think about, I don't know, trash removal and sewers, right? I think we would see that there's a big cost benefit or benefit instead of the cost for these types of interventions. And that's some of the work that I'm doing. So it was actually before the Trump administration, there was a national nature assessment. I was tapped to be a chapter author on the national nature assessment, which the Trump administration cut, but thankfully other funders have come in. And so now we're going to publish this document as United by Nature. And we'll have a health chapter, we'll have an economic benefit chapter. It's basically the first time where we're really going to quantify all the ways that nature may benefit us as a society, in the US at least. And I think, that I think will be a really powerful document, so that we recognize that this is not just an amenity for the rich. It's not just a perk. It's something that is kind of core to us and that we require to be healthy and to thrive.
Nice. Thank you, Professor James, for sharing your insights and your research with us today. We look forward to hearing and reading many more fascinating things from you. Thank you.
Great. Thank you.
Bye for now.